Hey everyone, we're back with another heart today. This is number 266 in our collection. And just a quick sneak peek at what we'll be discussing today. Looking from the left ventricular aspect here, we can see that there is in fact a ventricular septal defect. So today we will be talking about an inlet ventricular septal defect. But let's go ahead and start off as we usually do. The anterior surface of this heart would have been coming out towards the screen. Posterior surface towards the turntable, superior head here, inferior legs here, left over here, right over here. If we try to identify the right atrial appendage, at least externally, here we see that there is an appendage that appeared to have been triangular, broad-based, or pyramidal in shape, consistent with a morphologic right atrial appendage, at least externally. Obviously, some of this appendage has been cut away. And we do see already that there is some evidence of surgical intervention with some sutures here. So let's go ahead and open up the heart there. And when we do find pectinate muscles that spill outside the confines of the appendage, consistent with a morphologic right atrium. When we look at the oval fossa, it does appear intact. However, there appears to be a suture placed here. So perhaps there was an atrial septal defect that was primarily closed. Here we find the mouth of the coronary sinus guarded by the Thebesian valve. Here is the tendon of Totaro. And we know that the tendon of Totaro, the mouth of the coronary sinus, and the right-sided atrioventricular junction create the triangle of Koch. And at its apex is where we would expect to find the atrioventricular node. So we'd expect the AV node to live here in this heart. When we look at the right-sided atrioventricular junction, we do find that it's guarded by a valve with 3 leaflets, 1, 2, 3. This valve does have direct connections to the ventricular septum, consistent with a morphologic tricuspid valve. And it opens up into a ventricle that's coarse, has coarse trabeculations, and does in fact have a septomarginal trabeculation, aka a moderator band, all consistent with a morphologic right ventricle. Now, when we look inside this ventricle a little more closely, we do in fact find that there is a ventricular septal defect behind the tricuspid valve here. It's a little difficult to see from the right ventricular aspect, but right in here is a ventricular septal defect that lives behind the tricuspid valve leaflet here. And it doesn't appear that there's any fibrous continuity between the tricuspid valve and the mitral valve across this defect, consistent with an inlet ventricular septal defect. We've already seen it in the teaser a little closer, and we'll see it from the left ventricular aspect as well. But first, let's go ahead and take a look at the right ventricular outflow tract. Here's the septomarginal trabeculation. Here's the cranial and caudal limbs. The outlet here is intact. There is no outlet ventricular septal defect. We come across the first arterial valve here with 3 leaflets, 1, 2, 3, 3 sinuses, 1, 2, 3, and no evidence of any coronary arteries arising from it, all consistent with the morphologic pulmonary valve. Note that it's all supported by muscle, and that the annulus is truly this crown-shaped. It's not round or oval like we make it. Now, that's not to say the round or oval annulus that we create by imaging is not clinically helpful. That's just to say that the true annulus is not round or oval because the half-circle fibrous valvar leaflets have these myocardial triangles interposed in between them. Here is the pulmonary trunk. Here's one of the branch pulmonary arteries. Then we'll go to the posterior aspect of the heart. Let's open up the other atrium here. Here we open up the other atrium. We find a smooth-walled atrium consistent with a morphologic left atrium. Here is the left atrial appendage. Here is its opening into the left atrium. And we can see that all the pectinate muscles are confined within the appendage itself, all consistent with the morphologic left atrium. Then we come across the left-sided atrioventricular junction, guarded by a 2-leaflet atrioventricular valve does have a round or oval annulus here. We see that this valve does not have any direct connections to the ventricular septum, so that's consistent with the morphologic mitral valve. Now, when we look at this ventricle itself, fine crisscross trabeculations consistent with a morphologic left ventricle. Here is the left ventricular outflow tract, and now here is that ventricular septal defect, and we can see that this is an inlet defect, and in fact, there is no continuity between the anterior leaflet of the mitral valve and the tricuspid valve across or through this defect here, which remember would be the defining characteristic of a perimembranous ventricular septal defect. When we look at the left ventricular outflow tract here, we find another arterial valve with 3 leaflets, 1, 2, 3, and 3 sinuses, 1, 2, 3, and here is the right coronary artery arising from one of those sinuses or a little bit higher than that. This is consistent with a morphologic aortic valve. And once again, note that the arterial valves do not have a round or oval annulus. It is in fact this crown-shaped annulus. And we can see that there is in fact aorto-mitral fibrous continuity here, which is what we expect. So unlike the pulmonary valve, the aortic valve is not entirely supported by muscle. And then here is the ascending aorta. And we can follow the ascending aorta here. Here's the transverse arch, and here's the descending aorta in my hand. So once again, ascending aorta, transverse arch, descending aorta, and it does look like there's a ridge here, aka a posterior shelf. So it appears that there might have been coarctation as well of the aorta. And then if we look closely, here is an arterial duct as well. So here is an arterial duct from the pulmonary trunk to the transverse arch, right in the area where there appears to be a posterior shelf or coarctation of the aorta. So we've got a heart with an inlet ventricular septal defect and coarctation of the aorta with an arterial duct.